Thank you for listening to this PYA webinar recast. PYA is pleased to offer this alternative way to access our thought leadership. This is a recording of a previously delivered webinar. The information is accurate as of the date of the original event. The video recording, slides, and associated material for this and all PYA webinars are available on our website at pyapc.com. This podcast is for educational purposes only. It is not intended to be used as legal advice or an official opinion.
Good morning, everyone. Welcome to today's 100th episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is 2026 Inpatient PPS and SNF PPS final rules, key takeaways, and strategic implications. PYA is happy to present today's webinar on this important topic. With that, I'd like to introduce our presenters, Martie Ross and Kathy Reep.
Well, good morning, everyone. And as you can tell, we're in a bit of a celebratory mood here as we finally achieve episode 100 of our Healthcare Regulatory Roundup webinar series. Kathy and I, what, Kathy?
We have cake?
I hope so. There better be cake and ice cream. But Kathy and I started this mess back in May of 2021. We remain frequent presenters for the series, but a number of PYA experts have taken the helm here at HCRR. We are indebted to their contributions and look forward to having more, bringing you more experts besides our two faces in the future. We certainly could not do this without our amazing production team, our very patient and amazing production team, Matthew Lennon, Lori Robbins-Smith, Jennifer Tulin, and Dan Alton. Bless you all for putting up with us, including changing slides at the very last moment. And importantly, we are thankful for those who bring us the content we address every week. Thank you, Congress and CMS, because we started the very first HCRR, Kathy, was on the 2022 IPPS proposed rule. So we have made it through 5 annual Medicare payment cycles. But also during that period, we have had, the public health emergency waivers. We've had the Provider Relief Fund, No Surprises Act, price transparency, you name it. It has certainly been a while. OBBA. How could we forget OBBA as well? So it has been quite a time. As you see here, this is not a normal photo. This was courtesy of our production team to celebrate our 100th anniversary. Kathy and I are very pleased that we each look at least 35 years younger in this cartoon. We appreciate that very much. Although we still think bobbleheads would have been more fun. But enough celebration. Let's get to the meat of the matter. We're going to cover the federal fiscal year final rules that were published earlier this month. The big headline, of course, is always the inpatient prospective payment system rule. So we'll cover the payment rates. We'll talk about the reporting programs, and we'll focus in on TEAM, that mandatory alternative payment model that goes live at the beginning of next year. And then we will also run through the skilled nursing facility rule, the inpatient psych and inpatient rehab rule, the changes to the hospice payment rate. And as a bonus, at the end, we're going to talk about the new 340B drug rebate program, which is certainly causing a lot of consternation in the 340B world. So no further ado, truly, Kathy, take us over and talk about the dollars.
I'm going to do the dollars. Martie is going to do the quality and other programs, but let's just get started with the one that has, I would say, the greatest impact on the majority of those who are listening to the program today. Let's talk about the inpatient prospective payment system final rule. As proposed, CMS is using a 2023 base year to set the rates. For both operating and capital, they're using that as the base year. They have finalized a 2.6% increase in the base rate, which is based upon a market basket increase of 3.3% less 0.7% productivity adjustment. Last year, or this year, fiscal year 2025, we did receive a 2.9% increase. So that you can see, based upon the analysis that CMS did, we are looking at a lower increase than we received this year. We'll show you the actual numbers on the dollars shortly, but we're looking at a conversion factor of a little over $6,700. There were a number of commenters in addressing the proposed rule who were focused on the idea of CMS using the Bureau of Labor Statistics Employment Cost Index to measure labor costs. CMS kind of passed over these comments. They acknowledged that they were there, but they did not accept the comments and continue to address the determination of costs in the same manner as they have done historically. One area of concern, even though we are seeing a slight bump in the payment rate, they did for those hospitals with a wage index greater than 1, they are lowering the portion of your payment rate that is adjusted by labor. Currently, 67.6% of your payment rate is adjusted by labor. They are finalizing the proposal to reduce that to 66%. That means fewer dollars. If you take 66% of your base rate, adjust it by a wage index that is greater than 1, less money is being adjusted than it was when under the current year, when we're looking at 67%, almost 68% of your rate being adjusted. They did not make a change for those hospitals with a wage index less than 1 because a 62% wage index adjustment is statutory. That is as it is required in law. They are definitely kind of discontinuing the low wage index hospital program that they had put in place several years ago, was litigated. CMS was found to be, it was found that what they had done was inappropriate. But although they are discontinuing that program, they are keeping a budget neutral transitional exception in place for hospitals that have the most significant impact from eliminating that program. If you remember, that low wage index hospital policy applied to the bottom quartile of hospitals across the country, those with the lowest wage index, and it brought them up partially to a minimum threshold. Other provisions that were included in the final rule, there is an increase in the capital payment amount to $524. That's about a nearly $15 increase. The outlier threshold is being reduced by nearly $6,000. That means it will be easier for a case to become an outlier, and that is a positive for most providers. I go back to the proposed rule webinar that we did, Marty, and I was very hesitant as to whether or not the proposed increase in uncompensated care and disproportionate share would flow through, and that would be as proposed. It's actually higher than proposed. We're looking at a $2 billion increase in Medicare inpatient disproportionate share uncompensated care payments. So that is a significant positive for hospitals. A $192 million increase in new technology add-on payments, so additional dollars coming in there. And finally, for those who operate nursing and allied health education programs, they did not finalize a proposed change that they were making that really addressed how you calculated the allocation of administrative and general costs to total costs, what was allocated to allied health versus other departments. They did not finalize that, and therefore it is a positive impact for hospitals. Yes.
One thing to note is we are just about to open the window on applications for the new technology add-on payment.
Absolutely.
That process begins the end of August. You have until October to submit the application. So if you are in that position, now is the time to act.
This table just gives you the final payment rates of whether you are wage index 66%, those with a wage index greater than 1, and those less less than 1 at 62%. It gives you your breakdown in terms of the rates, also in terms of the penalty adjusters for those who are not meaningful users of electronic health records, or those who did not submit quality data or failed on both counts. So this gives you your breakdown from the final rule in terms of the actual payment amounts. One other thing that I wanted to call your attention to that was not in the inpatient proposed rule, this was actually in the outpatient proposed rule. And that relates to a proposal that I urge you to comment on, think about, and then comment on. But this would be revising the way the DRG weights are calculated. Currently, weights are calculated based upon your charge master rates adjusted to cost, all providers' rates adjusted to cost, to set the DRG weights for services. CMS is proposing in the outpatient rule that they would require, as a part of your Medicare cost report submitted on or after January 1, 2026, cost reporting periods ending on or after January 1, 2026, that you would report your Medicare Advantage plan payer-specific negotiated, I have charges in quotes, because charges is what CMS uses to reflect rates. So recognize your payer-specific negotiated rates would be reported at the DRG level for all of your Medicare Advantage plans. Concern, because they are saying that then they would use those Medicare Advantage rates to calculate the weights of your DRGs. And they would hope to use that methodology beginning in fiscal year 2029, although they are not sure as of now if it would be a direct conversion or a blend with the existing methodology and the MA rate-based weights. I don't know how it's going to impact the rates. I don't know what it's going to do, and therefore it's hard to really judge what this is, the impact of this provision. But I think it is something that we need to think about. If you think about your MA plans, your contracts, are they paying you an amount greater than the Medicare rate? Are they paying you the Medicare rate? Are they actually Medicare minus? I hope not, but take a look at it, because this will be concerning in terms of how this could actually play out in the weights of the DRGs moving forward. As you know, that they always include the long-term acute care payments policies, rules as a part of the inpatient rule. They haven't failed. They are increasing the payment rates for long-term acute care hospitals by 2.7%. And significant change from the proposal as it relates to long-term acute care hospitals is the outlier threshold. The outlier threshold is being increased from $77,000 to almost $79,000, but they had proposed an outlier threshold of $91,000 for a claim to become an outlier. You see on the slide the payment rate that is finalized for long-term acute, but recognize that the major issue, I think, on the long-term acute is really the fact that they did not impose that extremely high outlier threshold. Marty?
Let's switch gears and talk about the value-based programs within the IPPS program. And that starts with the Hospital Inpatient Quality Reporting Program. IQR was authorized by the Medicare Modernization Act of 2003, although we did not first collect data until 2013 and no payment adjustments until 2015. So apparently it takes a long time to modernize Medicare. But under this program, hospitals are required to submit data on selected measures. Those that fail to do so are subject to a 25% reduction in market basket update. Kathy provided that table from the final rule that specifies the amounts of reduction for our non-IQR hospitals. On an annual basis, CMS updates the measures and the reporting methods for the IQR program. This year was not an exception. They are modifying 4 measures. 2 measures that are complication rates and mortality rate measures are going to be broadened out in terms of the cohort included within the denominator. So for the first time, we will introduce Medicare Advantage beneficiaries into these calculations. Not quite sure what direction that's going to go.
No idea.
No idea. We've not seen preliminary data on this, but that will be the new calculation. And also they are shortening the reporting period from 3 years down, not reporting period, the performance period from 3 years to 2 years. And you see there on the screen when those take effect, which is pretty much immediately for the next payment, the payment year in 2027, which is based on 2025 performance. They are also modifying 2 measures in terms of the reporting requirements associated with them, and that's to the hybrid hospital readmission rate measure and the all-cause standardized mortality rate measure. A few more changes made to the IQR program. They will begin removing the COVID-19 diagnosed patients measure denominator exclusions, beginning with the FY27 program year. So program year means the period for which the data is collected, and then payment year is the following fiscal year. We collect data on a calendar year, and then we adjust payment on a fiscal year basis. They are removing 4 measures from the FY26 payment determination. So this means they're taking it, as they are now calculating the payment determinations for 26, they're removing these measures. That includes the hospital commitment to health equity, screening for social drivers, screen positive rate for social drivers, and the COVID-19 vaccination coverage measures. And finally,
just one comment on the issue of screening for social drivers. It doesn't mean you shouldn't be doing it.
Absolutely.
Because remember, it does impact the actual DRG weight, the DRGs that the patients fall into. So it's not something to stop doing. It's just, it is not a measure that is going to be used in your payment determination.
Yeah, in prior years, we added that add-on, well, but we did it. We changed it from no comorbidity or comortality to CC,
right,
for homelessness diagnoses. And to demonstrate that, you had to be capturing the Z code, and to capture the Z code, you have to be doing the screening, right? So there's still reason to do this. The other of note is that the terminology is changing. We have referred to these previously as social determinants of health or social drivers, and this administration will use consistently the term now upstream drivers. So it's broader in its application. And then finally, and this will be a common theme throughout, they are modifying the extraordinary circumstances exception, which excuses providers, which has historically excused providers from reporting requirements during natural disasters and similar incidents. And now, instead of always saying you're forgiven, we instead will permit delays in the submission of data. That CMS will have that flexibility going forward with future ECE events. Let's next talk to the Promoting Interoperability program. This goes back to high tech in 2009, which created the Meaningful Use EHR Incentive Program. We originally had, this was all carrots. So these were bonus payments you received for reporting certain information. It is now all sticks. It's a penalty for failure to report on these particular measures and requirements. This is a more severe penalty than IQR. It is a 75% reduction in the market basket update. And this, importantly, is the one program that applies to critical access hospitals as well as PPS hospitals. So CAUs that fail to report on promoting interoperability will see their reimbursement reduced from 101% of costs to 100% of reasonable costs. And of course, then there's sequestration, but that's a whole other story. Changes this year to the Promoting Interoperability program, and they're generally, I would say, fairly characterized these days technical modifications, but amending the regulatory definition of an EHR reporting period to be consistent with the change made in 2024, modifying the security risk analysis measure now to require hospitals and critical access hospitals to attest yes to both having conducted a security risk analysis and also having engaged in security risk management activities. So that is reflective of what we see in the HIPAA, the proposed HIPAA security rule changes, that we have both these required elements of risk analysis as well as risk management. Third, the modifying the SAFER measure to require hospitals and CAHs to attest yes to having completed the self-annual assessment using these updated SAFER guides that were published earlier this year. And finally, adding an optional bonus measure to the public health and clinical data exchange objective for submission of certain health information to a public health agency using the TEFCA standards. Next up in line is the Hospital Readmission Reduction Program. This is from the Affordable Care Act back in 2010. We actually saw the first penalties imposed in this program back in 2012. So this program is well over a decade old, but yet we continue to modify and refine it. In this case, hospitals with a higher than expected 30-day readmission rate can be penalized up to 3% of their base Medicare inpatient payments. So this is, if you are on the high end, but higher than what you would expect to see of readmissions, that's when the penalty kicks in, and it's a sliding scale up to 3%. Finalized changes to this program include refining all 6 readmission measures, again, to add the Medicare Advantage cohort beginning in the FY27 program year. So again, growing out that number of individuals whom we are reviewing for purposes of those measures. The good news here is they chose not to finalize the inclusion of MA data in the calculation of aggregate payment amounts for excess readmissions, because they agreed with commenters that there were serious reliability concerns with that data. So as we say, Kathy, comments matter.
They do indeed.
They truly made a difference here, because that would have resulted in several additional hospitals having been penalized going forward under the HRR program. Next up, they are reducing applicable period from 2 or 3 years to 2 years. Again, that's consistent, larger population of patients that are being included in these measures, so we don't need as significant a period of time to measure over. They are removing the COVID-19 diagnosed patient measure denominator from all 6 readmission measures beginning in FY27. And again, this updating of the ECE policy to allow for delays as well as actual exception from participation.
Just one comment on this, Marty. With the inclusion, I think, of the Medicare Advantage patients in the readmissions program, hospitals need to be looking at their agreements with the MA plans. In many instances, your physicians are ordering a particular type of post-acute care, and the plans are overriding that. I really think it is something that you need to, because now if, let's say your physician says home with home care, and the plan says they can go for outpatient physical therapy after a particular service, and the patient winds up being readmitted or having complications, it's going to impact you. From that readmissions perspective, I think you need to have perhaps some stronger language within your contracts to follow the direction of your physicians, not the plan's choice.
Exactly. The first year of this is going to be really interesting. So we'll see this again calculated for 27. It's going to impact calculated for calendar year 27 and then impacting payment year 29. So we'll be watching this one carefully to see the implications. Let's move over to the Hospital Value-Based Purchasing Program. This one is also from the Affordable Care Act, has been in place since 2013. This is kind of the Robin Hood approach, right? Take from all the hospitals 2%. So we withhold 2% of Medicare payments. That's roughly about $1.7 billion. And we're going to redistribute that money to the top performers. Okay, so those top performers are measured on 14 measures that go across 4 domains. You see the domains specified there on the page. So we take the low performers get less money. The top performers are going to get more money. So it's a redistribution. The program changes here. These will sound consistent. They're modifying the THA and TKA complications measure beginning in 2033 to include the MA cohort. And once again, changing the performance period from 3 years to 2 years. And again, see, that's a much longer delay for implementation in the hospital value-based purchasing program. Removing the COVID-19 exclusion from clinical outcome domain measures beginning in 27. Making technical updates to the hospital-acquired infection measures beginning in 2028 to reflect changes that have been made in those measures by the CDC. Removing the health equity adjustments for hospitals serving higher percentage of dual eligibles. Again, very consistent theme through all the rules this year is eliminating these provisions that have been initiated in the Biden administration to account for health equity, different populations served by different hospitals. We see the Trump administration unwinding that here in the 2026 final rule. They are providing previously and newly established performance standards for upcoming program years, so the levels you have to achieve. And then again, once again, updating the ECE policy for this program as well. Finally, last but not least, well, it is sort of because they didn't make any changes, but my favorite acronym in healthcare, the HAC program, the Hospital Acquired Conditions. This penalizes those hospitals in the top quartile in terms of hospital acquired infections. Those hospitals, that top quarter, see a 1% reduction in payment for all of their Medicare discharges from hospitals during the follow-up year. No proposed changes here except some technical updates to the HIA measures mentioned previously. Those will be implemented beginning in 2025. And once again, the update to the ECE policy. So there you have it.
And recognize, folks, on the HAC program, there will always be a worse performing hospital, or there will always be a worse performing quartile, no matter how good we are. Right. And therefore, there will always be that penalty. And under the HAC program, the way the legislation was written in Congress, it is a 1% reduction in total payment. Therefore, if it's an outlier case or something like that, your entire payment is going to be adjusted, not just your base rate.
Right. Unlike the other three, the other programs, it's base rate adjustments. This is the total payment adjustment. Thank you, Kathy. Great point. Okay, well, let's talk TEAM. Oh, there were such high hopes that TEAM would go away or be considered a voluntary and sort of a mandatory program. I think one thing very clear in the first 7 months of the Trump administration is that we like mandatory payment models, mandatory alternative payment models. We expect to see more of them coming forward. Again, Kathy and I have a bet going whether in the 2027 proposed rule, whether they're just going to make TEAM mandatory for everyone. So pay attention, even if you are not a TEAM hospital at this point in time. Very briefly, just to review on TEAM, it is a mandatory 5-year alternative payment model. Hospitals were selected at random. About 25% of all PPS hospitals are participants. These hospitals that have been selected are assuming responsibility for the quality and cost of care furnished from the date of surgery through the first 30 days following discharge from the hospital. If you reduce total cost of care, you get what's referred to as a reconciliation payment, effectively a bonus payment. But if you go above the target price, you're going to pay money back. You, the hospital, are going to pay money back to CMS. The idea here is to encourage collaboration among hospitals, physicians, post-acute care providers. The core to this program is the target prices. And you begin by calculating preliminary target prices. So before the beginning of each performance year, CMS calculates price standardized average hospital spending by episode type. Episode type refers to each individual MSDRG and HCPCS code. They do this for 9 census regions. So Price standardized means they get rid of all of the geographic adjustments, all of the adjustments made because of the quality programs we just discussed. Basically, truly treats as if everyone was paid a single national payment rate. Using 3 years of historical data to weight those specific prices as well. They exclude outlier episodes, they apply a prospective trend, and then very importantly, the last adjustment they make is to apply a discount factor, which is effectively CMS's guaranteed savings in this program, 1.5% for major bowel and cabbage and 2% for the other episode categories. Then there's an annual reconciliation process. So set the target price, you perform for a year, and then we're going to reconcile how the hospital did. For each qualifying episode, they determine what the performance year spend was. They compare that to the target reconciliation price. That is going to give them the difference on that episode for each individual hospital. They then apply a quality composite score, which will adjust the percentage of monies based on the performance across those quality measures. And finally, there's a stop loss, stop gain measure that determines then the final payment to the hospital or repayment owed by the hospital. The important changes in the final rule concern the low volume hospital adjustment. Lots of attention was on this. I have a lot of hospitals that have been selected for this program that have said we have very few episodes across these measures. And so what's going to happen to us? In the proposed rule, they had a laundry list of proposals that they were considering for how to account for hospitals with low volumes of certain episodes. And in the final rule, they have determined they will apply the less than 31 episode rule, meaning if for any episode category, you have fewer than 31 episodes during the baseline period, you will still have those episodes reconciled. So 3 years, go back 3 years, do you have 31 episodes? No, we do not. We're still going to, during the performance year, we're going to calculate the reconciliation. So apply your performance spend to the target, but no downside risk. So you still have the opportunity to receive a reconciliation payment. You'll just not owe anything back if you exceed the target on those particular episodes. So you're still, again, accountable for performance of all the other episode types. So if you are out on cabbage but in on major bowel, then we're going to calculate and be liable for reconciliation payment, well, receive reconciliation payments or owe repayment back to CMS. So that's how they finally ended up doing this. Note that this is going to reset each year because, of course, the baseline period resets each year. And so the fact you've been out 1 year does not guarantee that you're going to be out the next year. So I think it's actually
a lot of the low volume, the hospitals that consider themselves low volume based upon the final rule, the prior final rule. Right. We're hoping that something would come along saying, you don't have to be on the program.
Nope.
That did not happen. And I think they were kind of focused on, this won't apply to me.
Yeah. And it's
now
sort of
less time to prepare.
Yeah. And you have now, we understand that the data has been delivered to the hospitals, so you should be able to determine if you fall in the 31 episodes. Actually, this first year, it doesn't matter because no one sees downside risk this year, right? It's only upside this year. It's in year 2 in 2027 that the downside risk begins kicking in for most hospitals, not all, but most hospitals. And it's there then that this low volume hospital rule is going to come into effect. The other adjustment they made, actually it's a clarification more than an adjustment, is around the primary care referral requirement for team. They said that there are 2 options. The hospital discharge planning process completed before the patient leaves the hospital must include a referral to an established primary care provider that has been identified on admission. If no primary care supplier has been identified on the admission, it is then the responsibility of the hospital to identify a supplier to whom to refer the beneficiary. In doing so, it is incumbent on the hospital to consider the beneficiary's preferences. And the example they give there is you don't want to refer someone to a primary care supplier that's 50 miles away from their home. You should be considerate of their place of residence in making those requirements. Here's the good part, is they did clarify that making the referral is the obligation, and that there is no duty to actually go forth and schedule the appointment for the beneficiary, nor to confirm that the beneficiary actually did see a primary care provider during the relevant time period. So clarifications there, very helpful going up for the program.
But
finally,
Martie, if you were a patient who went to a particular facility because they were really good at joint replacements, as an example, but you traveled a good ways from home in order to do that, then at the time of referral, they're going to have to know, if I don't have a primary care physician, they're going to have to know who is in my market, who is within my community to refer me to.
That is exactly the expectation that CMS.
That's going to be a lot of work, I think, on discharge planners to identify who within a market, someone coming from 100 miles away.
Exactly. And it'll be, because in many instances, it's going to be a community whose hospital is not in team.
Right.
So you're trying to gather information in a process that doesn't exist at the other hospital. There were also 12 technical changes that CMS had proposed to the team program. You see them listed here. I would actually put you to sleep if we went through these, but for those that are in teams, you can appreciate that CMS is sort of, shall we say, they've sort of filed off the rough edges around different elements of the program to ensure that it operates more efficiently when it begins January 1st, 2026. It's not going away. Good news again, no downside risk the first year, but consider that a learning opportunity. And we need to start thinking about the collaborative relationships with our physicians. We need to think about interacting with our post-acute care providers, because 2027 is literally just around the corner these days. So with that, Kathy, back over to you to talk about SNFs.
Let's talk SNF dollars just for a minute. The last year, 2025, skilled nursing facilities saw a 4.2% update in their base payment amount. This year, again, a little bit lower than prior, a 3.2% increase in the rates. This is based upon a market basket of 3.3 plus a 0.6% market basket forecast error. I'm going to talk about that one in a minute, and then less a 0.7 percentage point productivity. The skilled nursing prospective payment system is the only system that includes a forecast error. If I got it wrong last year, let me make up for it and address it in the following year. So recognize the only program that has this, but it is built into the skilled nursing prospective payment system. They used a 2022 base year as opposed to the 2023 that was used for inpatient hospital reporting. And an area that they had proposed, they finalized as proposed, related to the code mapping under the patient-driven payment model and identifying where an individual ICD-10 code would map under the model in terms of which category it would go to. They changed code mapping on 34 services, and essentially the intent behind that was to better align with ICD-10 coding guidance and to provide more accurate, consistent, and appropriate primary diagnoses that meet the criteria for skilled intervention. Martie, back to you.
On the SNF quality reporting program, we are reversing last year's addition of 4 standardized patient assessment elements, so less data to be collected going forward, and refining the reconsideration policy and processes, allowing for extensions of time to file requests, and also addressing the extraordinary circumstances beyond their control. Kathy? Oh, value-based purchasing program. I apologize. How could we forget? This is removing the health equity adjustment to benefit SNFs that serve higher populations. Again, we've heard this theme before. Apply previously finalized scoring methodology to the SNF would then stay a potentially preventable readmission measure. So again, trying to refine that measure to be more reflective. adopting a reconsideration process to allow SNFs to appeal CMS's initial decisions, and then providing estimated performance standards for the 28 and 29 program years. So again, basically routine maintenance on the SNF value-based purchasing program.
Let's keep the story going in terms of all the final rules and look at the inpatient psychiatric facility PPS final rule. A couple of interesting changes here that I've been following the inpatient psych rule for a long time, and I'm surprised at some of the changes they made that are very positive. First of all, they are looking at a 2.4% increase using 2021 data. They used there was a 2.8% increase for the current year, slightly lower increase for 2026. They are looking at a 3.2% market basket increase, reduced by 0.8 percentage points for productivity. The change in the base rate is essentially going from $876 to $892 under the program. The labor share, a higher portion of the labor share is going to be, a higher portion of your rate is going to be adjusted by labor. Is moderate, but as was mentioned under IPPS, where they're lowering the labor share for those hospitals with a wage index greater than 1. Essentially what you're going to see now under inpatient psych is that more of your base payment amount will be adjusted by your labor share. So that could be a positive. It could be a negative, because if you have a wage index less than 1, you don't have that cushion that you had under inpatient, where anyone under 1 was capped at 62. So if your wage index is less than 1, more of your payment rate is going to be adjusted by a lower wage index that then could impact your actual payment amount. The fixed dollar loss threshold for outliers is going to be increased slightly, $39,000 compared to the current $38,000, meaning that, again, a little bit harder to become an outlier. But the areas that I was most interested in, as I said, having been following this program since it started, there is currently a 17% adjustment to the rates for inpatient psychiatric programs that are in a rural area. They are increasing that to an 18% adjustment to the rates. So your rates are going to go up. And if you are a teaching hospital, significant adjustment to the rate. Currently, it's an adjustment of 0.515. This is going to go up to almost an adjustment of 0.8. It will be 0.7957. So again, significant adjustment to your payment rates based upon locality and teaching status. These are being done in a budget neutral manner, however. Therefore, it does impact the actual payment rates going to everyone as they implement this in a budget neutral format.
Hey, Kathy, for purposes of this program, is that rural for payment or rural for status? Is that Miami or is it not Miami? I guess.
No, this is truly, it is in a rural location. Rural.
Yeah, it's been a hot issue.
Yes.
For the last couple of weeks, this idea that hospitals that can claim to be rural for payment purposes, and the fact that Miami-Dade County is rural, surprisingly, that's because it's all been reclassified. But
the thing that's interesting is really looking at that definition and the fact that it does come into play, and now it's getting a lot of traction in the media. I'm not focused on Miami. I'm saying in general, they're looking at various areas around the country. I think Health Affairs did an article recently, et cetera.
Yeah, I know we're going on a tangent, but stay with us. It's really going to come into play under the Rural Health Transformation Program, that $50 billion fund, because of how it defines rural facility, which would include those reclassified facilities, right? Did we decide that's where it was? Yes, you did, right?
I think we settled on, yeah, we think so.
Yeah, we think so. We'll see. Exactly. Yeah. Request for application apparently is going to be out in the next couple of weeks, so we'll see how they define it there. I apologize, a little bit of a tangent. Quality reporting program. Can I just quickly say that the changes are consistent with the changes made for the other quality reporting programs we've discussed previously? So Kathy, go ahead, back to you to talk about IRFs.
Rehab. But before I do rehab, let me just say it is our 100th episode, so we can go on a tangent. All right.
Okay, there we go.
Okay, inpatient rehab, again, the final rule, we are looking at a 2.6% increase in the rates, less again than it was for the current year. You can see on the slide the market basket increase of 3.3, less 0.8 productivity. Essentially, we are looking at a conversion factor of $19,000 compared to the current rate of about $18,900. So not a huge increase. No change in the labor share, but the labor share for rehab is set at 74.4%. At some point, I urge y'all to start thinking about labor share in terms of, look at what we just said labor share was for psych versus labor share for rehab versus labor share for hospitals, acute hospitals, and might want to start thinking about whether that should be reevaluated. The outlier threshold, they have decreased from $12,000 to a little over 10. They had proposed a decrease, but at almost an equal dollar amount to where they were. They had proposed $11,971. Again, this means that it will be easier for one of these cases to become an outlier. Quality.
Again, consistent with the theme we've seen throughout these rules, they are removing the vaccine requirements for IRF staff. They're reversing they're reversing last year's addition of more standardized patient assessments. Again, consistent with this de-emphasis, shall we say, on social determinants of health, and similar to what they've done with SNFs, amending the reconsideration policy and process to make it more user-friendly.
Hospice was the last rule that they published in this series of final rules, but that doesn't mean we're going to be done after hospice. I just want to clarify that. But let's talk about hospice. The 2.6% increase, again, less than the current year, which was 2.9. They always use the hospital inpatient PPS market basket, less productivity. They essentially copy inpatient. But I've given you on the slide the rates that are finalized for 2026 based upon routine home care, continuous home care, inpatient respite, and general inpatient care. You can see where the rates fall compared to where we are now. Again, very moderate increase in the actual rates. The hospice cap, as expected, has gone up from the current $34,465 to $35,361. For those who aren't familiar with the hospice cap, this is essentially a per patient cap that is not applied at the patient level, but is applied to the total spend for all hospice patients at a particular hospice over the course of the year. There were some policy clarifications that were included in the final hospice rule. Essentially, we've had an existing requirement that said only the medical director or his physician designee could recommend admission to hospice care. They have now changed this to say that any member, physician member of an interdisciplinary group could recommend admission to hospice care. It's interesting that they are making this change because it now will align with certification requirements and conditions of participation. So kind of scary that their previous requirement did not align with the COPs. And they have also said that the hospice face-to-face encounter attestation must include the physician practitioner signature and date. The fact that it is a signed and dated clinical note will not suffice. It needs to be the attestation. It doesn't need to be a separate document. The signed and dated clinical note will suffice. You don't need to do a separate attestation. So this should eliminate some administrative burden on submitting or signing two different documents on the part of the ordering physician.
And then finally wrapping up on the hospice quality reporting program is that the submission reporting system is going to begin accepting data from hospice outcome and patient evaluation instruments at the beginning of the new federal fiscal year on October 1st. And that is in line with the start of HOPE collection data. And so that finally, we are reaching the point of implementation of that new system, which should streamline data collection and also streamline the reporting program, the quality reporting program as a whole. So there you have it, the 2026 federal fiscal year Medicare payment rules. But we got a few minutes, so let's talk about some other interesting things that have been happening impacting the 340B program. Since a number of, I would assume, our attendees today are at hospitals that participate in the 340B program. And this is going to be, let's choose the word disruptive. Kathy, what do you think?
I think very disruptive.
Very disruptive. So the 340B program certainly has been under a lot of scrutiny. It is no secret whatsoever that the pharmaceutical industry hates this program because it does whittle into their profitability because they're required to sell certain drugs to certain providers at a significant discount. There have been legislative proposals that have been focused on transparency in the program, requiring providers that participate in the program to report on their use of funds, the completion of program integrity audits, and we even want to have a national clearinghouse to prevent duplicative payments being made to providers, our safety net hospitals. Many manufacturers have been imposing restrictions on covered entities' access to 340B pricing under their contract pharmacy arrangements. And now we have several states that are pursuing legislation that prevent covered entities from doing that. So it's interesting to see the states now kind of throwing their elbows around. Some hospital associations have been very effective in promoting that legislation to protect the safety net hospitals in their states. The bad news, which we talked about under the OPPS proposed rule, is that CMS has announced that it intends to conduct a new pricing survey. And we are expecting that the results of those surveys will result in a reduction in Medicare payments for 340B acquired drugs. And for a lot of safety net hospitals, it's that difference that makes up a significant amount of money that they then use for community benefit. So they buy the drug at price A and Medicare pays them price B. Now we know we had the whole kerfuffle, shall we say, beginning in 2018 when CMS reduced the rates down. And then the Supreme Court said you can't do that because you didn't do a survey. The statute says you have to do a survey to change that rate, CMS. So CMS said, okay, we're bad, so we're going to raise the rate back up to what it was. And we're going to have a whole repayment of the dollars and adjustments to base rates and everything else we discussed under the OPPS proposed rule webinar. But the kicker here is that we've had an executive order directing CMS to do the survey. They've now announced that they're going to do a survey. And we anticipate that it's going to result in probably beginning in FY27, or even calendar year, FY27, some significant reductions in 340B payments. So be prepared for that coming. We were surprised back in 2018 when that adjustment was made by CMS. Caught a lot of hospitals off guard and created a lot of budgetary issues. Be warned that this is the direction we're headed for 2027. And finally,
on that, they will be surveying all hospitals for their acquisition costs, not just 340B providers. And they have said that the survey will go out likely early calendar year 2026. So recognize it's coming, and they are expecting to see your response.
We still have on the table the president's plan for shifting program oversight from HRSA, Health Resources Services Administration, for the 340B program, over to CMS. And we anticipated that would happen. We'll expect more stringent reporting requirements being imposed, as well as additional auditing requirements. This is, again, still up in the air because it's part of the president's budget, this proposal, and as part of the whole reorganization of HHS, moving pieces around, shifting budgets, creating the Administration on a Healthy America, the AHA, all of that's in play, except we got to wait for Congress to step in and tell us what the FY26 budget is going to look like. They get back in session on September 2nd. The government shuts down if they can't figure out what to do with discretionary spending on October 1. So expect a very exciting 4 weeks in Washington, D.C. on that front. But that said, let's talk about the drug rebate pilot program. We had several manufacturers that unilaterally said, we're no longer going to sell the drugs to you at a lower price. Instead, we're going to sell to you at the standard price, but we're going to give you the opportunity to submit invoices showing how you sold the drugs, and then we'll give you rebates. Not surprisingly, those hospitals that were subject to those rebate programs from manufacturers sued and said they can't do that. That is contrary to the language of the statute. And the court said, you're right. They can only do this if if HRSA permits them to do so. So on July 31st, HRSA said, yeah, we're going to let you do that. And we're going to announce a pilot project that will allow manufacturers to require covered entities to purchase drugs at wholesale acquisition and then submit claims data to receive rebates. It is limited for now to CMS Medicare drug price negotiation selected drug list. So it's a limited number of drugs, although it's very clear from the announcement that HRSA is willing to expand the program to additional drugs. The timeline for implementation of this pilot project is really rapid. HRSA is accepting comments on the pilot project through September 2nd. You see there the link to submit your comments on this. Manufacturers have to submit their plans to HRSA by September 15th. HRSA will tell you if you're successful in being part of the pilot project on October 15th, and it all starts on January 1 of 26. The pilot program does, on paper, have a number of protections for covered entities that the manufacturers have to give at least 60 days notice before they begin switching to the rebate model. They have to pay for all the IT and administrative costs that are related with data submission, so it's not intended to be an extra burden on covered entities. They have to provide responsive technical support and customer service so that you can't, hide behind the system broke as a reason for not paying the rebates to providers. They have to make sure that only requiring necessary data, not imposing additional reporting requirements to slow the process down. They must issue rebates or deny the rebate within 10 days of claim submission by the covered entity, and they will be subjected to specific reporting requirements on the rebates activity for CMS can monitor. HRSA can monitor the effect of the pilot program. So they're going to be focusing on claims processing times, denials and other relevant metrics. So it's something definitely worth paying attention to and being prepared for. Again, don't want to get flat-footed here when on January 1st, you're expected to pay average wholesale price. And you're like, what? What happened to my 340B pricing? But make sure you are investing in the ability to garner these invoices and be prepared to submit them for those manufacturers that would like to go forward. So stay tuned on this front.
Because of a limitation that not all drugs from a manufacturer that would be on the list,
right,
you might be dealing with paying 340B, paying a lower price, getting the discount on one drug and having to go through the rebate program on another. I think that adds to administrative burden, and I think that is even worth a comment.
So we've reached the end. We are coming back for episode 101. Actually, we're not coming back for 101. Barry Mathis, John Cross, our IT security experts, are going to join you on September 10th to talk about cybersecurity and artificial intelligence related compliance concerns. Ooh, that sounds interesting. I'll be listening for sure.
We get two Marines doing that.
Yeah, they're both Marines, so watch out. They are. We call him Scary Barry around here because he will definitely make you turn your computer off at night. On October 1, the first day of federal fiscal year 2026, Kathy and I are going to do a Washington update. We decided to delay until the actual end of the federal fiscal year to see exactly what's going on in Washington so we can give you a complete picture. But please, if you have other topics you'd like to see us addressing in these HCRR webinars, please leave a comment. If you have questions after this presentation, please include the questions for you, and anything else that would make this a better product for you, please let us know. We are here to be useful, not just to hear ourselves speak. believe it or not, Jennifer, we are not here just to hear ourselves speak, so back to you.
Thank you for listening to this PYA webinar recast. The video recording, slides, and associated material for this and all PYA webinars are available on our website. If you have any questions or if we can help, please contact us at pyapc.com. Thank you again for joining us and have a great rest of your day.